Hello, I hope you're doing well. This pandemic has certainly affected everybody. Hope you're keeping yourself well, practicing spatial distancing and doing those things that we need to do. For doctors, we have the additional challenge of how do we continue to relate in a useful and meaningful way with our patients. How can that happen when they don't come to the office? Well, that's one of the things I wanted to talk to you about. This is a test that I envisioned, about 15 years ago. SPARCS stands for Spaeth Richmond Contrast Sensitivity. It's a way of assessing people's vision online, and it works. We've been proceeding in a very orderly way, I think a good way, so that we now have data showing that SPARCS works in patients with macular degeneration, glaucoma, cataract, and we have a normative database. So we have a good idea how well it works and in whom it works and how good or bad it is about detecting visual loss. Good care often demands detecting change. Change for the better, change for the worse. Sometimes we also need to know the rate of change, such as in glaucoma, because the treatment is going to depend upon that rate. So establishing that rate validly is important. Recently, we've just finished a study following patients with moderate glaucoma for 4 years, longitudinally. We did all kinds of different tests, OCT, fields, contrast sensitivity with 2 different methods, discs, quality of life measures, all kinds of things. What we found at the end of 4 years was that the test at baseline, which best predicted who was going to have progressive visual field loss, was the SPARCS test. What we also found was that the tests that correlated best with what patients could actually do, because in this study, one of the things we studied was their ability to perform the activities of daily living. And what correlated best with that test, that performance-based test, was SPARCS. So we know that SPARCS works as well as other measures in detecting change in vision, and also that it correlates better with the performance-based measure than the other measures that we used. We know that, however, only for glaucoma. We haven't studied patients with macular degeneration or other conditions longitudinally. That needs to be done. But one would assume that the results would be similar to those that we found in patients with glaucoma because SPARCS tests both central and peripheral vision. Now I want to talk to you about home monitoring. To establish a trend of a change, you need 2 things: precise data points and enough data points that you can smooth out the variability that inevitably occurs with every type of testing. And this is what I think is the game changer, is you can obtain many, many data points with SPARCS much more easily than you can with a test which demands being done in the office. At home, a person can test himself or herself as frequently as needed or as requested or as wanted. But that's not possible in the office. So it should be possible using SPARCS to establish a trend much more quickly and easily than when relying on office testing. However, there's a caveat. We haven't established that. We know that when a person self-administers SPARCS in the office, it's as reliable as when the test is administered by a technician. We don't know that that's the case when a person self-administers the test at home. In fact, one would expect there to be more variability. There may not be, and we have some preliminary data that suggests that there isn't more variability, but we can't say that with certainty yet. So we have to find that out. Because if indeed SPARCS is as reliable when self-testing at home as in the office, we have a very exciting test. Even if it's not quite as reliable, it's still exciting because the ability to obtain multiple data points is so facilitated by home testing. We think that's pretty exciting.